Thank you, everybody, for sticking around as we round out the day. Thank you again for the invitation. Always enjoy coming back to the Midwest. And so we'll likely have some time left at the end just because some of the slides have already been covered. And so we'll talk about just bispecific antibodies and sort of where we see them in B-cell lymphomas at this point. And so we'll just separate the talk into discussions of large cell lymphoma, and then we'll talk about follicular lymphoma as well. So here are my disclosures. And we've shown, and I've shown this slide quite a few times, obviously, and how we sort of look in the construct of the bispecific antibodies. And for the most part, if we look at this, blinatumomab is how we all started. There's plenty of data with blinatumomab and large cell lymphoma from the group in Germany. And that has sort of become sort of the key point of how we transitioned to using really bispecific antibodies and sort of trusting their efficacy within the United States and Europe and other countries studying the more traditional CD20, CD3 bispecific antibodies that we're using. So the biggest difference, obviously, is the inactive FCC region that's in the more newer constructs, and obviously this allows these antibodies to have longer half-lives, which makes these a bit more convenient than what we saw with blinatumomab, which, as we know, is given as a continuous infusion. And so obviously these are the four major ones moving forward, obviously three of which have FDA approval, and the fourth of which is hopefully trying to get approval at least in follicular lymphoma. So if we look at large cell lymphoma, we have two approved agents. We have epcoritamab and glofitamab, for which we'll talk about the more recent updated data from ASH with long-term follow-up. And as we discussed, odronextamab is being studied as well, and also potentially may have an approval sometime in the future. And then there are many of combination therapies with bispecific antibodies and other drugs, such as chemoimmunotherapy, as discussed before by Dr. Smith, and with antibody drug conjugates, at least in the relapse refractory space. I guess that is out of order. So the EPCOR NHL-1 study was the original study that evaluated epcoritamab. In this study, we evaluated epcoritamab at 0.16, 0.8, 48 milligrams. And thereafter, it was given for every week for the first cycle. So for cycles 1 through 3. For cycles 4 through 9, it was given every other week. And then from cycles 10 plus, given once a month. So this is a treat to progression or intolerance medication. And so unlike the other medication, this is, again, an indefinite therapy in this patient population. So with the long-term follow-up, obviously the patient characteristics, obviously, for the most part haven't changed, but again, gives some idea of the patients who've progressed versus the patients who have remained on therapy, especially for those in a complete remission. So over the next couple of slides, they will discuss the duration of response, median duration of response, and the progression-free survival and median progression-free survival of this medication. And so the key takeaway from these upcoming slides is that there are a subset of patients who are obtaining a complete remission and able to maintain response with that remission, thus indicating that there are durability of responses in this patient population, some of which are post-CAR T in this patient population. And so some of the biggest questions we have when we talk about CAR T-cell therapy and bispecific antibodies, obviously, is that we know that there is a curative potential for CAR T-cell therapy. The question is whether bispecific antibodies have that same potential in this patient population. Now, while the follow-up for this is still relatively short for what we can see from the original CAR T studies, the fact that we are starting to see some sort of plateau for some of these patients do suggest that patients who get a remission may maintain that remission in large cell lymphoma. The question that we'll have to answer as we move along is that, is continuous therapy the way to go about it, or can we do a fixed duration and still maintain remissions in these patient populations and hopefully get some resemblance of cure? So if you look at the long-term efficacy, the duration of complete responses in this patient population, obviously the numbers are very small, but the duration of complete response is 36.1 months. Again, they did separate those between transformed large cell lymphoma and regular large cell lymphoma, but for the most part, we'll stick to just large cell lymphoma, as the transformed part was sort of taken out the original sort of approval from the FDA. But if you see of the 157 patients, there is a subset of patients who maintain their remission, and those who maintain a remission have a very good chance of keeping that remission long-term as they move along. So looking at the PFS in this patient population, again, the 36-month PFS was 53% for this patient population. I'll bet the overall progression-free survival was quite short, around 4.4 months. But as we know with studies with large cell lymphoma, we tend to have a very high attrition rate early on as these patients who don't respond come off very quickly, and then everything else as far as the tail are from the long-term responders. So again, given that about 50% of these patients who responded are still maintaining that progression-free survival benefit in this study, again, is an encouraging, and as we get more long-term follow-up, again, as we especially get closer to the 5-year mark, again, if these patients do still maintain that response or remission, the thought will be that these patients have maintained some sort of cure. So again, if we look at the biggest issue with the bispecific antibodies, it is the cytokine release syndrome. Again, no new updates in this situation. Again, they did provide some increased data as far as other strategies to mitigate cytokine release syndrome in this patient population. So no, it isn't like what we do in the myeloma space where they give tocilizumab, when they give teclistamab, but in this situation, given hydration and steroids, was used as an optimization to reduce the rates of cytokine release syndrome in this patient population in a hope to keep patients out of the hospital, which in most healthcare systems is a very important sort of caveat, especially as we try to transition into more community settings where you may not have a reserved hospital bed for these patients. And this is the optimization here where they were able to lower the rates, especially of grade 2 and above cytokine release syndrome with hydration, and again, the use of dexamethasone as a corticosteroid partner in this situation versus prednisone, which is also an option during the clinical trial. So at this ASH meeting as well, there was updated data from glofitamab. So the key caveat from the glofitamab sort of situation, other than, again, this is a fixed duration again. So you get 1,000 milligrams of obinutuzumab prior to 2.5 milligrams, 10 milligrams, and 30 milligrams. And again, this is only given for 12 cycles and stopped. So that is a key major difference between that and epcoritamab and how it's administered. And again, looking at the incidence and rates of cytokine release syndrome with glofitamab, you expect it with a 2.5 milligram dose, whereas with epcoritamab, it typically happens with a 48 milligram dose. There isn't as much steroid utilization with glofitamab. You typically get dexamethasone 20 milligrams on day 1. You don't get the 4 days of steroids that you typically use with epcoritamab in this situation. And so, fixed duration, the infusion schedule may be a bit more convenient, but again, this one does have a fixed duration of stopping. And so again, the major question of whether that's better than sort of continuance is something we still need to answer. So looking at the 3-year follow-up, which technically should be 2-year follow-up because all of the data is really reported out at 24 months. As you can see, relatively speaking, the rates and results are fairly similar to what we see with epcoritamab. If you do a very crude indirect comparison, it does appear that epcoritamab may have an improvement in the progression-free survival and duration of response curve compared to what we see with glofitamab. But again, indirect comparison, given the patient populations are different. And so again, it isn't a true apples-to-apples comparison. And again, if we look at some landmark analysis here, whether after cycle 3 of end of treatment, to try to get some better predictive sort of ability of patients, if they get a complete response, will they maintain that complete response? So as you can see here, it's 31.1 months with the end at the end of cycle 3. And if you look at the end of treatment, it was somewhere in a very similar phase. Now, the duration of complete response for this patient population, as you can see, is 26.9 months. Again, slightly less than what we saw, again, with the epcoritamab situation. But again, this situation, again, is really at 24 months and not 36 months from what we saw with epcoritamab. Safety-wise, again, of what we can see, safety-wise, no new signals. Again, as I mentioned before, the biggest incidence and rates of cytokine release syndrome are with the 2.5 milligram dose. And again, sort of the key point, looking long-term with the bispecifics and the infection risk, you can see there is immune reconstitution and recovery after around the 9 to 12-month mark after completion of glofitamab, which is important as, again, as we know B-cell aplasia is a very important component that comes along with use of bispecific antibodies. And so the concern of a long-term infection risk is something that still needs to be teased out in this patient population, especially as we start comparing infection risks that come with the bispecific antibodies versus CAR T-cell therapy. So this is just an indirect, again, comparison. As you can see from this chart, it gives you sort of the response rates that we see with the long-term follow-up of these two molecules. Overall, there is more similarities and differences between the two for the most part. And again, it does appear, at least at this early time set, that again, there is maybe a higher percentage of patients in complete response with epcoritamab. But again, the downside to epcoritamab is a simple fact that this is a continuous therapy. The glofitamab trial did evaluate patients and allow for some retreatment. To date, the data on retreatment does not look very encouraging with glofitamab in large cell lymphoma. Now, whether that is due to loss of CD20 antigen or other things that sort of mitigates the benefit of this drug on retreatment is still yet to be determined. But again, I think we know we are getting more and more information about the long-term responsiveness and durability of these drugs, but to date, we still don't necessarily have all that information at this current time. And so the million-dollar question is always, do you do bispecifics before CAR T, or can this be possible? At least with the single-agent drugs, I mean, to date, I would say CAR T is still the better modality to use if you can get a patient to CAR T. Now, whether that changes with some of these combinations that are coming along, I mean, that is more so up for debate. But again, we will need more information with that. So STARGLO was already touched about, so I won't necessarily go on this in detail. I think the biggest question we have with STARGLO, obviously, is just the lack of patients enrolled within the US and Europe. If we look at the subset analysis, the majority of the overall survival benefit from STARGLO did occur in patients treated ex-US and outside of Europe. And so the question really becomes, was the overall survival benefit related to the treatment itself, or just a lack of sort of other treatments that are available here in the United States? And again, using glofitamab together with GemOx in that situation, sort of promoting the benefit. How we apply this in the US, if this were to get a second-line indication, again, in this situation, I would still say to date it would probably benefit patients to try to get to CAR T-cell therapy if possible. Again, as we said, this comparison set, at least within the US, did not necessarily show a significant benefit in US patients. And actually, if you look at the confidence intervals, they overlap. So there was not a statistically significant overall survival benefit in United States patients treated within the US and also in Europe. So lastly, at least with large cell lymphoma, we'll talk about another bispecific ADC combination. So this one uses loncastuximab, which is the CD19 drug antibody conjugate, which uses a PBD payload. In this situation, this was evaluated with mosunetuzumab and glofitamab plus loncastuximab. We'll only talk about the glofitamab data, as this one showed a more substantial synergistic benefit in this patient population. But as you can see, loncastuximab is given for a fixed duration in this sort of treatment regimen versus what is continuous or to intolerance in the original single-arm study that led to the approval of this medication in relapsed refractory large cell lymphoma. And glofitamab is given as we would standardly give it with obinutuzumab pre-treatment, and then as a step-up dosing, and then every three weeks for 12 cycles. So this is just the patient characteristics. I just highlighted the patients with large cell lymphoma. As you can see, the majority of the patients had DLBCL NOS, but there was a mix of other high-grade and transformed diffuse large B-cell lymphoma in this patient population. A median age was around 73, so it is a bit of an older patient population. Looking at cytokine release syndrome and other adverse events, as you can see, the majority of the events were grade 1 to grade 2. So this, again, suggests that, again, using these ADCs can mitigate some of the severity of cytokine release syndrome in this patient population, thus hopefully potentially allowing more outpatient use of this treatment and less inpatient hospitalization for these patients. So again, this is just a grade 2, grade 3. And if we look at efficacy, if you want to focus on the patients who got the 150 microgram dose, so this is the middle box, you can see the complete response rate is around 78% in this small patient population. And so based on this, again, this cohort will be expanded and we will look for longer follow-up of this combination. And this can be anecdotally compared to some of the polatuzumab combinations we see with ADC, with the bispecific antibodies, and see if we can get some sort of comparative analysis. So this is just a list of some of the ongoing studies with patients with large cell lymphoma. As we mentioned, there are several frontline studies with bispecific antibodies. And again, in the second line space, as already discussed, the SUNMO study was mosunetuzumab versus GemOx. This study has completed accrual, and we'll get a readout of this study probably relatively soon. My guess is everybody would suspect, I would suspect mosunetuzumab would have a benefit over GemOx, given this was in a relapsed refractory patient population, and most patients who are refractory obviously don't have much of a great response to gemcitabine oxaliplatin. So turning our attention to follicular lymphoma, again, there were several studies that are looking at relapsed refractory, and we'll touch on some of the frontline, and again, some of the combination relapsed refractory studies. So in this patient population, we have mosunetuzumab. So mosunetuzumab in this study was given as an IV infusion, 1, 2, 60, then 30, every 3 weeks for either 8 or 17 cycles based on attainment of a complete response. In this patient population, there is a sub-Q formulation of mosunetuzumab being studied, which is 5, 45, 45, then every 3 weeks again for a total of 8 or 17 cycles. Again, subcutaneous formulations, some sort of ease in use in some of these situations, but for the most part, we do know there's a different kinetics with the onset of cytokine release syndrome when you give this subcutaneous versus intravenously. So this long-term follow-up demonstrates a very high overall response rate, complete response rate. And again, if we look at some of these high-risk patients, subsets with follicular lymphoma, does not appear to be much of a difference in efficacy and complete response rate compared to the overall patient population, suggesting this is a very effective treatment to use in patients with follicular lymphoma. So looking at long-term response, there is some durability and plateaus of the curve. Obviously, I'll bet these are not as substantial or impactful as what we see with follicular lymphoma, but as Dr. Flowers alluded to earlier, until we can really get an idea of whether CAR T-cell therapy is curative in follicular lymphoma, this is a very good sort of treatment to use, as it does not have some of the same high-grade risks, especially neurological complications, and is a bit easier to administer in certain situations. And again, for most patients, given the frequency of dosing, is not a big inconvenience in their everyday life. So again, as we can see, most of the patients with follicular lymphoma had grade 1 CRS, and when this was approved in this patient population, there is no requirement for hospitalization with mosunetuzumab, and which is a little bit different from what we had with the 2 approvals in large cell lymphoma. So epcoritamab was also studied in follicular lymphoma. The initial dosing of epcoritamab was very similar to what we saw with large cell lymphoma. The issue that came up with that dosing was that there was an increase in the amount of cytokine release syndrome compared to what we saw with mosunetuzumab, and was probably not an ideal sort of situation. And so to optimize or improve this, they did add an intermediate step-up dose at 3 milligrams, which was provided the benefit of improving the cytokine release syndrome profile to be very comparable to what we see with mosunetuzumab. Again, very similar to what we discussed in large cell lymphoma, the 2 differences between the 2 products. Again, mosunetuzumab is fixed duration, while epcoritamab is given until intolerance or progression in this patient population. So again, comparatively speaking, the overall response rate and complete response rate of epcoritamab in this patient population compares very favorably to what we see with mosunetuzumab, and overall it compares very favorably to other treatment regimens approved in third line beyond follicular lymphoma. So again, efficacy isn't a question in this patient population. And again, as we mentioned before, with the improvement and addition of that intermediate dose, you see a marked reduction in anything above a grade 1 cytokine release syndrome. So again, this allows us to position this as a completely outpatient regimen. So for those of you who only have epcoritamab on formulary, obviously there's a bit more nimbleness with this, as you can use it for both large cell lymphoma and follicular lymphoma. And again, gains more experience with this, but again, just an addition of that extra intermediate dose in patients with follicular lymphoma to reduce the risk of cytokine release syndrome. This is likely not to be an option in large cell lymphoma, as again, as some of us already know, there's the race to get to the first full dose with epcoritamab precludes us adding an extra intermediate dose because of a concern for disease progression. So turning attention quickly to frontline therapy. So this was discussed earlier. So this was produced data from Dr. Fauci from the ASH, looking at mosunetuzumab subcutaneous treatment in patients with frontline follicular lymphoma. Again, just not to belabor the point, but there was a percentage of patients with grade 3A, which is true to be quite difficult sometimes in the patient population to treat. And some people prefer using R-CHOP in this patient population over R-CHOP, over bendamustine rituximab. But again, 19% of the patients, and as we already saw, very high overall response rate in this patient population, still very early follow-up, but it appears to be some durability of response. Now again, the question will be, was these patients have relapsed? As you can see to the box to the right, some of these patients at progression of disease are noticed to have CD20 negative disease, which obviously presents a bit of a problem in the relapse refractory space. Now, with the advent and likely approval of the INMIND study, where we use tafasitamab plus lenalidomide, that may not be much of an issue in this situation, as you could just substitute tafasitamab for rituximab. But in this situation, as of right now, if a patient does lose expression of CD20, that does mitigate at least the use of R squared in the second line setting, and can potentially be a problem with some other regimens, such as the Rosewood regimen that was discussed before. So looking at other second-line therapy, so this was discussed as well before, but in this situation, they did use 2 different dosing regimens of epcoritamab. They used a more accelerated dosing regimen to get to the more convenient monthly dosing with 2B versus 2A. There was no real difference in rates of cytokine release syndrome and safety in this patient population. And so again, my guess is that with this sort of more rapid ramp up to the full dose of epcoritamab in combination with lenalidomide for fixed dosing, this is likely what we will see moving forward as a recommendation if this were to become an approved regimen. So what we can see is very durable responses in this patient population. As you can see, the median duration of complete response and the median duration of response are very similar between these 2 patient populations. And you look at the subset analysis, there's not really appear to be a high-risk subset population that does not respond to this combination. As discussed earlier, there are more complications and side effects when we give lenalidomide with bispecific antibodies, given the immunogenic nature of lenalidomide, which could lead to increased risk of rash and other sort of immune manifestations, and additionally the increased risk of neutropenia in this patient population. So in conclusion, obviously there are multiple approved bispecific antibodies in large cell lymphoma and follicular lymphoma. As we move forward in this situation, likely in large cell lymphoma, with the push to move these drugs to the frontline setting, so that the major arguments of bispecific versus CAR T will likely lose a lot of weight. As my guess is, with one of these studies will prove to be a positive study, and then we'll then be grappling what to do in the relapse refractory setting when these patients progress on bispecific antibodies, especially those who may not necessarily have a durable response to frontline use of bispecific antibodies, which will likely position CAR T to still be very well utilized in the second line space. Thereafter, with patients with later relapses, the question is, can you reutilize the bispecific antibody in this diffuse large B-cell lymphoma space? At least for what we have from the early readout from the glofitamab trial with retreatment, that may be an issue. But again, in these situations, can you give a bispecific with another molecule or some other chemotherapy, such as GemOx or other chemotherapeutic regimen? Will that be able to overcome some of the resistance in this situation? With follicular lymphoma, again, I would expect to see the bispecific antibodies move into an earlier line of therapy, especially at least the second line space with some of these R squared plus bispecific studies that are ongoing. Whether this will translate into a frontline regimen is something yet to be determined, but typically we tend to try to push our best regimens to the front. So I would not be surprised to sort of see a bispecific antibody in the frontline space, which will allow more utilization and obviously, hopefully, greater uptake of bispecific antibodies outside of academic centers. So with that, I'll end, and this will thank everybody at the Lymphoma Center at City of Hope. Thank you.